Good afternoon, everyone. Well, now that you are very well acknowledged, myself included, about venous lymphatic insufficiency, I think it's time to talk about arteries. Let's talk about arteries. My expertise as a vascular surgeon at St. Thomas is actually in complex lower limb revascularization. And I think we needed to raise the awareness on the importance and time dependent importance of revascularization to all our patients that are presenting with leg ulcerations. Those are my disclosures. I'm quite balanced, but I think the point on this regard is the importance of collaborating actively with industry. And as healthcare professionals, we need to be leading industry, not to be pushed by, but inform and leading our colleagues in the industry of pharmaceutical or surgical technologies. So again, a very quick touch on the differential diagnosis. As we said, we mentioned a lot about venous insufficiency, skin conditions, and so on. But this is taken from what we call the Bible of vascular surgery, the Rutherford textbook of vascular surgery. There are multiple etiologies that may either individually or in a contribution lead to a vascular ulcerations. But the attention should be led mainly on two main pathophysiologies, the venous insufficiency and the arterial insufficiency. And of course, as we all know by now, venous insufficiency is very prevalent, is the most common condition leading to leg ulceration. But we cannot ignore the peripheral arterial disease, the arterial component. And my argue is that actually the PAD in association with tissue loss or rest pain is a time-depending factor. As you probably know, there are now very clear guidelines on the referral pathways for patients that have leg ulceration and PAD. Any of you knows what's the timeline between referral and arterial treatment as recommended by the Vascular Society of Surgery? Well, this has actually become a sequence, so it's a very important target. So the recent vascular guidelines suggested that all patients that have an arterial critical limb ischemia, so rest pain and tissue loss, meaning arterial ulcerations, should be treated within 2 weeks from GP referral. We were talking about a 2 weeks treatment for venous ulcers, which is, if you may allow saying, is not usually an immediate limb and life-threatening condition. Well, actually for arterial condition, which comes with the risk of developing sepsis or gangrene, the target is the 2-week treatment for outpatients and 1-week treatment for inpatient. And if we look at the breakdown of the pathways, the patients that have an arterial ulceration should be vetted to see a specialist within 24 hours from the GP referral, should be seeing a consultant and have a cross-sectional imaging, meaning CT scan, within a week from that referral, being discussed in a specialist lower limb MDT the following week, and within 2 weeks have arterial surgeries. So it's very, very ambitious target. And I have to say, in London, we are kind of struggling to meet that. As St. Thomas, although we are the largest volume center in this country, together with Birmingham, but we are achieving the target in less than 50% of our patients. And so that's something we need to work with. But that's where the primary care and where most of you play a crucial role, because that initial referral that triggers the pathways, so the clock starts with you. And that's where specialist care and primary care should work together. We need to close the gap between the services, and you have a crucial responsibility. And my question to you is, how many of you know their vascular surgeons, their vascular team? few of them, but how many of you have a direct link to them? If you see, oh, Grace, a couple, 3, 4, okay, great. Because actually what happens in my personal experience is that I receive referral from GP saying, my specialist nurse, my practice nurse has seen a patient. Reportedly, the patient has an ulcer that is not either thriving with a conservative management. Could you please see the patient? So that gap is probably unnecessary and is a total waste of time. Of course, from a specialist point of view, we need to have that personal relationship with you, with your services, so that we can trust the referral coming. Okay, because then we can reach the other extreme of having referral saying, you know, oh, I saw the patient, the Doppler is a whooshy sound, can you please see the patient? So, of course, that doesn't really kind of put us in that kind of a positive scenario where we want to collaborate. But if we trust our team, if we trust our nurses, and then we can build that relationship and close the gap between primary and secondary or tertiary services. And why is it important to immediately treat peripheral arterial disease with signs or symptoms of critical limb ischemia? The reason is that if the patient has a peripheral arterial disease, so follow the yellow circles. If the patient has a peripheral arterial disease, yet has no critical signs, so if the problem is just a matter of claudication, then the prognosis is quite good. Patients with non-critical PAD, they will end up with the risk of limb loss of just 5% within a year. So addressing those kind of patients to preventive arterial surgery is to be advised against, because the surgery itself, even with the modern keyhole technologies, is a very risky undertaking. On the contrary, patients that present with critical limb ischemia, meaning rest pain or tissue loss, leg ulcers, at 1 year, 50% of them, more than half of them, will be either dead or without a limb. And quite interestingly, the one that dies, the more likely die of other reasons, other cardiovascular reasons, heart attacks, strokes. So picking up, identifying patients that have an arterial leg ulcer means that not only we can save their limb, but we can save their life even for non-limb related complications. Of course, when it comes to classifications and guidelines, I would like to encourage your critical thinking. Okay, classifications are designed to simplify complex pictures, but classifications are very limited. Okay, and that's where your expertise, your experience as clinicians, nurses, comes in a role. When it comes to critical limb ischemia, the classification is very simple and straightforward. Okay, so as we said, patients that have ischemic rest pain or minor or major tissue loss, those are the red flag, the critical limb ischemia, CLI, or more recently we are using a different acronym, CLTI, chronic limb-threatening ischemia. There is a European classification that is called Fontaine, and the American one, Rutherford, pretty much are the same things. However, as I said, the classifications are very simplistic way of looking at things. That's a kind of an example. You would think that all these criteria would narrow down your case, but actually, you know, you have a very two different kind of personality that may look, they may reflect the same classification. So that's when, as I said, your critical thinking and your knowledge needs to be applied to the individual case, patient-centered care. So With regard to leg ulcers and specifically foot ulcerations, we are now implementing a more multidisciplinary classification. It's called Wi-Fi. That stands for wound, infection, and ischemia. As I said, it's very pertinent to the diabetic foot condition, but can be also utilized for non-diabetic leg ulcerations. Again, in the pictures here, you have two patients that would be included in the previous very simplistic classifications of critical limb ischemia. Both patients have tissue loss and both have a peripheral arterial disease, so both are critical limb ischemia. But they are very different in terms of wound and in terms of ischemia. So if we are going to look at all the three different variables, okay, we can see that in the Wi-Fi classification, the patient at the bottom with a very demarcated shallow foot ulceration is actually stage 1, meaning very low risk of limb loss. And I would be very happy for the patient waiting more than 2 weeks to be optimized and to be prepared in view of intervention. Whereas the patient above, which has active spreading infection and an ABPI of 0.5, is classified in a stage 4, so immediate limb-threatening risk. That's the patient that I would admit directly from my clinic or from your own clinic right into hospital and have a revascularization possibly within 5 days from that. And just let me be also a little bit controversial when it comes to ischemia and the measurement of perfusion. That is a key element. And I know that there are the guidelines, for example, the one from the National Wound Care Strategy that suggests early compression, which in principle, I think it can be a very useful advice, but again, cannot be applied to everyone, not even just by looking at the red flags, because the reality is that we know from physiology that if we halve the perfusion of a limb, that means shutting off completely the circulation system, both arterial and venous return. Meaning that if a patient, in theory, has an ankle pressure of 60 millimeter of mercury, in general, that would kind of represent an ABPI of 0.8. And if you apply 40 millimeters of mercury of compression, waiting for your vascular surgeon to see him, from that moment, you will have a shut off of his circulation. So that's why it's important to have a direct link to your vascular surgeon and to ask, is it safe to start compression, or do you need to see him earlier on? And from personal experience, I know it's quite rare, but I've seen a very tragic complication of it. I've seen a patient last week, my reg started K2 bandaging in view of a CT scan, just by relying on Doppler sound. And when the patient came back, the ulceration has dramatically worsened. And the CT scan showed a very calcified occlusive disease of the tibial arteries. So that was very dramatic. And I've been through the process of a colleague of mine going to court with negligence and failed supervision to her nurses in the community because the patient underwent compression leading to limb ischemia and limb loss. So again, we need to be very critical in our thinking. Okay, so where we are in vascular surgery. Yesterday in my speech, I was mentioning how vascular surgery started in the trenches of World War I, but actually when we look at what we are doing today, we are probably still, or we were till a couple of years ago, we were still working with the physiology of the 17 and 1800, meaning that the whole purpose of vascular surgery so far has been just to open up the artery, to have a better diameter, a luminal gain of the artery, thinking that that's enough to improve the flow and to improve the oxygenation to the foot and the tissues. So we are relying on the physics as we study in high school of the 17 and 1800. Laminar flow, improve the diameter, job done. Well, actually, unfortunately, that is not as simple. Based on that concept, until a few years ago, basically vascular surgery in the lower limb, arterial revascularization, was intended as either balloon up the artery, do the angioplasty. Okay, this is now called the POBA, plain old balloon angioplasty. It's a very effective name, but you wouldn't be surprised that that name comes from actually industry, saying that, oh, if you just use a balloon, that's a plain old school. You need to do something more. So we have implemented the use of stenting. Of course, you all know about stents. And although there are quite interestingly development in the technology of stents, for example, this is a very good stent that can be used across the knee where there's lots of bending of the artery. It's very flexible, resistance to compression. And the third option, of course, is the bypass surgery, harvesting a vein normally from the leg and building a bypass that can go even down to the foot. So all these three concepts were based on just open up the artery or bypassing the artery to provide the flow. And that surgery, of course, comes with risks. That's a selection of complications from my own catalog of complications, my own personal. As you can see, when you balloon the artery, especially when the artery is small and frail, and typically, for example, in young women, you can end up with dissections. You can see here a tear in the wall of the artery. When you use stents, especially across the knee joints, quite typically, either in the early or late days, the stent may crush, may clot, or even displace. And then when the whole stent from the groin to the knee is blocked, it's very, very difficult to retrieve the stent. Until now, the only bailout option would be to move it to a bypass surgery, meaning a very invasive, aggressive surgery. But the reality is that the circulation is much more complex than those 1700 physics. It's not just a matter of gaining space in the artery to improve the flow. Even in the most simplified diagram of hemodynamic of flow, there are so many variables, and physics laws that should come into the equations. And one of the most important one that are now driving and informing our new way of doing surgery is compliance, meaning the ability of the artery that is made of muscle and adventitia and connective tissue to respond to the heartbeat and to keep pulsating the flow from the heart to the foot. And that compliance, that active work of the artery is often impaired in our patients by the degree of calcifications. That's again when your Doppler test may be deceiving, because even if the flow is still present in the artery, the burden of calcifications across the wall of the artery may impair the circulation. And this study shows that there is a very exponential relationship between the calcification and your flow in the artery itself. And that's where the modern approach to vascular surgery comes into this game. So we are now being able to try to change the morphology and the compliance of the artery. So interestingly, we have moved from the plain old balloon angioplasty or stenting, and that was like 30 years ago, to a new way of doing keyhole endovascular surgery with delivering drug-eluting technology. You may have heard, especially in the heart, stenting, that we use either balloon or stents that deliver drugs that try to treat the artery itself, preventing the re-narrowing, the restenosis of the artery. So that was called drug-eluting technology. We are now moving from that to the next step, which is improving the vessel compliance. So we call that vessel preparation. And the technology comes to a great help. There are two ways of doing that. One is the rotational atherectomy, and the other one is the intravascular lithotripsy. So I will just touch base with you on that, and I'll, in the next slides, although they are quite technical and specialistic, but I would like to take you with me in the cath lab and in the operating theater to see what happens when we perform arterial surgery. So this is a typical atherectomy device. Okay, there are few different atherectomy devices, but in the UK, this is the most used one. So as you can see, it's a catheter, same as we do with the balloon. We go as a keyhole in the artery. The difference is that this device has a rotational blades that drill through the plaque. And at the top of the catheter, there is a port that at the same time aspirates the clot as it works through the tunnel. So it's very useful when the arteries are small, arteries that you don't want to stent because of their size or their calcification. Okay, this is an example of a young a female patient, and by definition the artery very small. You can see about, you probably cannot read here with the light, is between 3 and 4 millimeter artery, where normally an artery in the thigh, the superficial femoral artery, is about 6-7 millimeter, and we don't have stent less than 5 millimeter. Oh, I mean, we do have stent, but we know that they clot almost immediately when they are too small. So in this specific case, we managed to drill, I don't know if you can see here, probably you see better on the TV. We drill through the arteries and position where the yellow arrow is, we position a basket, a filter, because we don't trust completely the aspiration of the atherectomy. So we position a filter in the same way that we use filter to prevent a stroke during carotid procedures, that tries to capture all the debris that are produced by the atherectomy device. And the result is to go back to an artery that has been completely debulked from the blockage, and is also an artery that, because the calcifications and the plaque has been removed, will be more prone to respond to the drug that is delivered with the drug-eluting technology. So that was the artery before, a very extensive blockage in the femoral artery in the thigh level, and that's the result after. So what we call a restoration to the complete integrity of the artery. Another example, actually you can see now the running image of the catheter that is drilling through. In this case, the patient had a previous stent that was completely blocked. As I said, until now, the only option to retrieve a blocked stent was to undergo a bypass surgery. Now with these atherectomy devices, with this drilling technique, we can try to salvage occluded stents. And here's the result now after the procedure of the flow through the artery. The common femoral artery, the profunda, which is a branch running in the thigh, and the main superficial artery and popliteal artery are now flowing like a normal artery. Those are the tibial arteries, just to confirm that no clot has moved farther down to compromise the circulation in the foot. Of course, that is a complication. Okay, so it's not easy and it's not a straightforward procedure always, and that's why no indication to do preventive surgery, because even with all this fancy technology, what could happen is that the clot that we have tried to drill or balloon or stent higher up may end up being displaced in the artery of the foot. So those are tibial arteries. Here's the ankle. You can see what happens. The clot has cut off completely the circulation in the foot. And when that happens, it's a very difficult task. Normally happens at the end of a 3-4 hours procedure, and you realize that all you have done has now caused even a bigger trouble. In this case, we were quite lucky because just by giving vessel dilators, nitrates, and heparin, the circulation was restored. We may argue that with the atherectomy, we see lots of those, but because the clots that are displaced are very small, because they've been drilled through, they've been broken down, normally they tend to resolve quite quickly. And that's the second kind of a breakthrough technology. It's called the shockwave, intravascular lithotripsy. And we at St. Thomas's have been the first center in Europe to use it in the tibial arteries, and probably one of the biggest centers still now for all the circulation. The concept, again, is revolutionary. It's the same technology that you may have heard for kidney stones, okay? Is lithotripsy. So it's an ultrasound-based technology that breaks down the calcifications in the same way that the calcium in the kidneys can be broken down. So we have a catheter with a balloon, and inside the balloons there are those emitters that are producing a sonic wave. So the whole catheter is connected to a plug. There is an electric impulse. The electric impulse is transformed in a bubble wave that produces a sonic wave. And all these waves are able to generate a 50 atmosphere pressure. So a huge pressure that is released against the calcium and breaks down the calcium. So the whole idea is that by breaking down the calcium that is within the wall of the artery, we are going to improve the compliance of the vessel, and not only to gain the lumen, the space for the flow, but to make the artery kind of elastic and mobile again. Look what happens in vitro. Okay, this is a piece of calcium, a calcified plaque, and every sonic waves tends to break down the calcifications. It's very, very powerful. Again, like everything in technology, there is never a one solution for all. The key is to use a technology for your specific patient. The indication is the key. In the same way you use dressings. There's not one dressing for everything. Okay, the ability of the clinicians, the healthcare professional, is to identify what technology works better for that specific case at that specific time. So the sonic wave, the ultrasound intravascular lithotripsy is indicated for patients that have very calcified blocked artery, but with no fresh atheroma, no fresh clot. Because otherwise, while you are breaking down the calcium, the fresh clot would go everywhere, and it could be a disaster. On the contrary, the atherectomy device with the drilling and aspiration is very good for those patients that have relatively fresh clot that can be sucked through. Okay, that's actually my first case of intravascular lithotripsy. Was done just 3 weeks before the first lockdown. Elderly patient with a circumferential mixed etiology ulcer. Okay, definitely venous stasis and dependent edema, venous insufficiency as well, but most importantly, okay, and peripheral arterial disease, a blocked distal SFA and proximal popliteal artery with a lot of collateral vessel that were good enough to keep the foot itself viable. The foot was actually pink with good capillary refill and even almost acceptable Doppler signals, but definitely not enough to heal a mixed etiology ulcers. And remember, mixed etiology ulcers may account up to 1/3 of all ulcerations. Okay. Oops. Again. So it's very important that in the differential diagnosis, even in the ulceration that have all the characteristics and features of venous insufficiency, you put as differential diagnosis number 1 peripheral arterial disease. And that's why, in my experience, if a patient, even with a so-called venous ulcers, has no palpable pulses or an ABPI less than 0.8 or an ankle pressure less than 60 millimeters of mercury or ideal toe pressures assessment, all these patients should immediately red flag for arterial problem. So in the case of this lady, I used the intravascular lithotripsy balloon. Okay, it looks like a normal balloon, but the difference is that it's not exerting any pressure. This is a balloon inflated at just at 4 atmosphere, meaning it's just touching the artery, it's not applying any pressure, it's not tearing the wall of the artery, it's not squeezing the plaque, it's just sitting there. And at that point, the sonic wave starts doing the job, breaking down the calcium, and with no additional requirements, the artery was restored to normal and with no embolization. And this is quite amazing, because you would think if you break down the calcium, where is all the calcium going? Why is not the calcium going down to the small arteries of the foot or the toes? But physiologically, most of the calcium in the arteries is in the media. You know, the 3 layers of the artery: intima on the inside, media, and adventitia. Most of the calcium is in the media, in between the walls. So when we break down the calcium, it stays there. It doesn't travel down. The difference is that when the calcium is broken down, the artery opens up and becomes more elastic. And what happened to this lady is that despite no compression therapy, unfortunately, because at that point, after revascularization, I would have strongly advised to go and have aggressive compression therapy, but during lockdown, that was not an option, unfortunately. But just by leg elevation and a better arterial circulation, it took longer than it would had if she had compression, of course, but she managed to heal completely. And again, going back to indication, each lesion, each patient may benefit from a different approach with surgery. Or even in the same patient, a different plaque, different disease needs to be approached specifically. So in this patient, we had the blockage of the artery, of the femoral artery, from below the groin to above the knee. This blockage was not calcified. There was just a chronic atherotomatous plaque, but with no calcium. So that was drilled through with the atherectomy, with the drilling device and the filter, and then ballooned with a drug-eluting balloon. restoring a very good circulation here. But below the knee, the arteries that are very compromised were extremely calcified and extremely small. So although there are drilling devices for the tibial arteries, that would have been an extremely risky undertaking. So for those arteries, I use the shockwave technology, so much more gentle and less risky procedure, and the result was excellent. Of course, this is quite expensive. I never told my managers because probably they would have sacked me by now, because of course the cost of these devices are approximately 1,500 for the shockwave, and it's probably a little less for the atherectomy device, but on top of that you use drug-eluting balloon, which is other several hundreds, and so on. But we are doing studies on quality of life and long-term outcomes, so it's clear that all the money spent for a good outcome on the table is then money saved in the long term and in the community. So where all this technology is leading to is leading to this kind of paradigm shift in the approach of arterial disease. As I said, atherectomy, shockwave, meaning that we can prepare the vessel to then receive all this technology of this drug-related technology. And to facilitate the whole process, we also using a new technology which is called the intravascular ultrasound imaging. So we are now looking with ultrasound inside the artery to see what's happening before and after we do the surgery. And that has allowed us to extend the range of surgery that we are allowed to do. We can enter the so-called no stent zone. There are areas in the body where stents should not be used at any cost. A stent in the groin is never a good idea, because that may easily blocked and may reduce the ability of going back with the bypass surgery. We can push with the new stents, but believe me, it's not a very good idea. Yes. So I'll probably skip other images, but I will just limit it to a couple of slides more. So extending the indication means also that we can approach, we can do surgery that we normally would not do, even according to these new guidelines that were published based on a randomized controlled trial published on the European Journal of Vascular Surgery, which suggests that we should do a hybrid surgery of the arteries in the groin, in the pelvis, if there is a critical limb ischemia, but the contraindication would be the presence of calcifications. Well, actually, I replied to that publication with an editorial on the same journal, pointing out that actually with the vessel preparation technology, we can treat those patients that were considered untreatable. And you can see here, this is a pre-op CT scan. Again, it's very important to plan your surgery very carefully. The arteries were small, calcified, and definitely not meeting the criteria of that study. Also, for the patient's kind of anatomy, and it was not a very easy approach to do open bypass surgery. So nowadays we use this hybrid approach to surgery. So we can improve the circulation in the groin, and that's called the femoral endarterectomy and patch reconstruction. So kind of an old-fashioned surgery to prepare the artery in the groin to become a keyhole entry for those modern technology. So the groin was prepared, the artery was crossed with a wire, and with the shock wave balloon, you can see the balloon that is very narrowed where the plaque is, and after 5-6 cycles of shock waving, the artery has regained the complete diameter. And so that's the result of the procedure. There was a residual tiny narrowing in the iliac artery that normally we could have ignored, but considering the patients being obese and high risk, I could not take any chance to go back for further surgery, so I use a very short stent. And so that's the result before and after. There were other slides, but I think due to time constraint, I'll end here. Thank you.